So finishing up the cardiovascular system is chapter 22, and that's the circulatory system. So remember, the cardiovascular system, the CVS, cardiovascular system, really is composed of three different things that we've talked about. So I'd like to say the heart is really the muscular pump that maintains blood pressure to move blood, which is the vehicle by which things are transported throughout your body. They're transported through your blood, which is powered by the heart in this closed system. So what a closed system means is you have the systemic circuit, which begins and ends at the heart, and then the pulmonary circuit, which begins and ends in the heart, right? And it's a closed system, and there's blood inside the system, and the heart maintains the pressure by which the blood actually will move in one direction. So that's really what your blood pressure is. It's a certain amount of force or pressure that is created by the muscular pushing of the blood, and then how much volume of blood is in this closed system. So the vessels by which this blood is circulating in this closed system is your circulatory system. And your book does a really good job. I like this book. The one thing it doesn't do that kind of bothers me is it doesn't put the arterial system or arterial system and the venous system on the same diagram, right? It puts them on two different diagrams. But if you look at these, I'll tell you, they are, where you have deep veins, you have deep arteries, or where you have deep arteries, you have deep veins. And you don't have superficial arteries, but you do have superficial veins. So arteries, deep arteries, I should say arteries, and deep veins are side by side throughout your body. In addition, the venous system has dual drainage. And what that means is that you have two sets of veins. So you'll see light blue and you'll see dark blue, and the dark are the deep and the light are the superficial veins in your arms and legs. And that's because we keep more of our volume of extra blood in the venous system. It's a low pressure system. And so we do have extra blood. Obviously, you guys know this on some level because you can donate blood and you're not going to die. So you know you have to have extra blood available to you. You can also bleed a bunch and you're still not going to die. So you have extra blood laying around, and it's laying around in your venous system because you have more blood vessels. You have twice as many in the arms and legs, and it's also a low pressure system. So again, the cardiovascular system is a closed system, meaning that blood being pumped by the heart begins at the heart and comes back to heart, right? It's a closed system. And this blood must stay in motion in order to maintain homeostasis or just plain stay alive, right? If you guys know CPR, cardiopulmonary resuscitation. It's all about compressions, right? You just want to keep the blood moving. Every so often you blow some oxygen in there with your mouth, but for the most part, you've got to keep the blood circulating. And if it stops circulating, then you're going to start to have tissue damage and organ damage and organism damage. So heart has to keep moving blood, right? And blood's pumped from the heart to the cells of the body, the systemic circuit, as well as the pulmonary circuit to the lungs at the same time. In addition, you have that coronary circuit that we talked about in chapter 21. Again, I want to point out the volume of blood being pumped by the heart is a measurement called cardiac output. So cardiac output is a measurement. And this measurement of cardiac output, this is really sloppy. Sorry, guys. Let's try doing this a little bit better. So, cardiac output. Cardiac output is a measurement in liters per minute. It's how many liters of blood are you pumping in 1 minute? How many liters of blood does your heart pump in 1 minute? right? So it's a measurement of your heart function. Now, at rest, everybody has a basic metabolic need of around 5 liters of blood per minute to be pumped in order to stay alive, right? So this is like your basic cardiac output. And everybody needs this, Mr. Couch Potato or Mrs. Couch Potato or elite athlete. Everyone needs 5 liters per minute to stay alive. It's your basic cardiac output at rest. Now, when you start exercising and need increase in O2 and get rid of waste and increase glucose, right? So you need more stuff when you start exercising. And because of that, how do we get more stuff to our cells is you increase your blood delivering stuff, right? And so your cardiac output can go anywhere between, 6 liters per minute all the way up to 30, 35 liters per minute when exercising. So that's a big jump. And so I want you guys to understand that cardiac output is equal to your heart rate, which is, we measure it in beats per minute, which is contractions per minute, right? So how many times does your heart contract? I'm going to make a little heart there. Heart contractions per minute. And you have to multiply that times what is called, oops, the R didn't show up real well. It's called stroke volume. And stroke volume is the volume pumped by ventricle in one contraction, right? So there's a certain volume of blood that's being pushed out when the heart contracts, pushed out of the ventricle when the heart contracts. That's the stroke volume, and that is measured in liters per contraction, okay? So when you look at this whole equation, no, that's not going to show up, right? So when you look at this, you have cardiac output in liters per minute, and it's equal to heart rate in, instead of contractions, I'm going to say beats per minute, times stroke volume, which is liters per beat, right? I'll put heartbeat in case you guys are wondering. So you can, if you guys remember math, you can basically do this and cross out beats. And so you end up with liters per minute, right? And when someone is super fit, like you go to the doctor and they take your pulse, one of the reasons they're looking at your pulse, because if you have a cardiac output in liters per minute, and it's roughly around 5 liters per minute for your average person, and your heart is a muscle, right? And so if it's a strong muscle, if your heart is a strong heart muscle, it's going to have a high stroke volume because it can pump a large volume of blood in one contraction. It's super strong. It's, instead of lifting a bunch of weight, it's going to push a lot of blood because you do cardiovascular exercise and your heart's been conditioned and worked out in its cardiovascular gym there when you're running or swimming or biking or doing something aerobic. And so your heart muscle is getting stronger, and the stronger it gets, the more blood it can push out in one contraction. So if you have a really high stroke volume, you can have a really low heart rate to meet 5 liters per minute. Because if the stroke volume goes up and 5 liters per minute is a constant, then that means the number of times your heart actually has to contract goes down to meet that 5 liters per minute. And that's why people with strong hearts have lower resting heart rates. And if you don't believe me, I'll show you in one more mathematical. So if it's 5 liters per minute, right? And we don't know what your heart rate is, but you can pump 1,000, no, it wouldn't be 1,000. So we're gonna say 1 liter per beat. I'll try to stay consistent here. 1 liter per beat. And let's see, the reason why I sound like I'm confused is it's easier to show you guys in milliliters. So I'm gonna say 5,000 milliliters. And we're missing, we don't know heart rate, right? So how many beats per minute times, if you have a stroke volume, that's 100 mLs per beat, right? Heart rate only has to beat 50 times to equal 5, which would be, you know, if we 5,000 milliliters or 5 liters per minute. If your stroke volume was really bad, right, because your heart, so this is strong heart. If you have a weak heart and you're only pumping 60 mLs per beat, so this is weak heart, right? Then how many times does your heart have to beat to hit 5 liters per minute, right? And so how would you figure that out? Well, I'm gonna get out my calculator, but basically what we would do is have 5 liters. Well, again, I have to make it in, you have 5,000 milliliters per minute and divide by 60 milliliters per beat to equal beats per minute. And so I'm going to get out my trusty calculator on my phone because I don't want to mess this up. And so you would basically have to have your heartbeat around 83, 84 beats per minute. So strong heart only has to beat 50 times per minute. Weak heart has to beat 84 times per minute. So the weaker your heart is, the more times it's going to contract. So I think that's super important to understand, especially in medicine, why you're taking a resting pulse. It's an indication, first and foremost, if someone is just in there for some kind of well check, they're not sick or anything, they're just going in there for some routine meeting, filling a prescription or whatever. And they go in there and they're not stressed and they're not worried, they're not sick, and they have a resting heart rate that's like 100 beats per minute. You have to start wondering about how strong their heart is as a muscle. So it is kind of a non-invasive way to get a snapshot of you know, how conditioned their heart is as a muscle. Now, heart rate can be overridden by the autonomic nervous system for a variety of reasons. And so you would look into those if this person was otherwise a healthy person. But understanding why it's important to get an accurate pulse or beats per minute, I think is basic medicine. So pulmonary circuit, again, begins at the right side, right? You can say pulmonary valve, you can say right atrium, and it ends at the left atrium. Systemic begins at, you can say left atrium, or aortic valve and ends at the right atrium. These are closed, it's a closed system, right? They all begin and end at the heart. Coronary system begins at the coronary sinus in the aorta and ends, I'm sorry, aortic sinus in the aorta and ends at the coronary sinus into the right atrium. Remember, arteries are vessels that transport blood away from the heart, and veins are vessels that are transporting blood to the heart, and capillaries are the exchange vessels. So what I want you to realize is that here's the heart, and you have the aorta, and arteries are just going to be a series of branching, right? So arteries are branching right? So these are all arteries, and because they're vessels leaving the heart. And at some point, they're going to become exchange vessels, and we're going to call those capillaries, right? So this is the tissue bed, and you have stuff leaving, right? Because these are exchange vessels, these capillaries. And then after things leave the circulatory, like leave the capillaries and the tissue bed, there's no reason for that blood to go on. And so what happens is veins are a series of merging, right? So veins are merging until they get back to the heart. And so these would be veins. But it's still a closed system. It's just capillaries are the exchange vessels and where things can leave and come back in. And then it really becomes merging of vessels that we are now calling veins because they are returning blood back to the heart. Blood, again, is going through all these circuits with every heartbeat. And it's also important to realize a few other things here. So I said arteries are branching. So here's the aorta, and we have this first branch, which is the Brachiocephalic Trunk. We have the left common carotid, we have the left subclavian, we have the right common carotid, and right subclavian, and it's just branch, branch, branch. All these branches off these arteries, right? And so with every branch, the pressure in the circulatory system, systemic circuit, is going to drop, right? So the highest pressure is going to be next to heart, right? In the aorta, because that is where the heart is really just pushing that blood out, and the pressure is going to be the highest. With every branch off the aorta and every branch off that branch, the pressure in the system drops. And so by the time you get down to your toes or your fingers, the pressure in the system's a lot lower. And then it goes through capillaries, which drops in diameter. So you can increase the pressure to push things out and then pull things back in. So hydrostatic pressures push stuff out of the capillaries, and osmotic pressure pulls fluid and things back into the capillaries. And then these veins begin to merge, but at this point they have to fight gravity, right? Going back up. And so the pressure in the venous system is low to begin with, but it's about 0 when it reaches the vena cava. So lowest pressure is in veins, and 0 millimeters of mercury pressure in superior vena cava, inferior vena cava. And so because of these things, the anatomy is going to be different in the arteries and veins. Arteries and veins run parallel to one another. Again, arteries carry blood away from the heart, veins carry blood to the heart. But because arteries are a high pressure system, the walls are going to be thicker and able to withstand more pressure. And they're going to have more elastic stretch, because as the pressure is great, and these thick walls with thick muscles is going to push back against that blood and keep moving the blood forward. So that's what blood flow is. It's going to help continual blood flow. Veins, on the other hand, have to carry volumes of blood. That's where you keep your extra blood. And they also have to fight against gravity. They tend to be thinner walled, so they're not high pressure system. You take blood out of your veins. Most of you guys know on some level that if an artery gets cut, you have to tourniquet it or try to block off flow, because it's a high pressure system. So every time your heart beats, it's going to really blast blood out of that artery if an artery is cut. If you cut a vein, it kind of, you stick a needle in your vein to draw out blood, and it kind of trickles afterwards, but it's really easy to put pressure on a vein and kind of get the blood to stop if you're healthy and normal. It's just a much lower pressure system. Capillaries are thin and thin-walled. They're really one cell layer thick, and they are there for exchanging things. So back to the anatomy of the blood vessels, except for capillaries, they have 3 layers. They have the outer layer, which is the adventitia, or depends on the area it's in. They have the media, which is the muscular layer, and the intima, which is really the endothelial layer. And the vessel walls are thick. So the layers, the innermost layer is the tunica intima, meaning internal or intimate. And it's really just endothelium of the blood vessel. It's the lining. The tunica media or middle layer is smooth muscle, and this is involved in vasoconstriction. So vasoconstriction will constrict, and say if this is your blood vessel diameter, if it constricts, the diameter gets smaller, right? So decrease diameter. So vasoconstriction decreases the diameter. Vasodilation will increase diameter and make the vessel bigger, right? So this is normal. So this middle or muscular layer, it's smooth muscle, and it can constrict and make the diameter of the blood vessel decrease. And if you decrease the diameter and you increase the pressure in the cardiovascular system or circulatory system, and if you increase the diameter, you're going to decrease the pressure in circulatory or cardiovascular system pressure. All right, so the outermost layer, the tunica adventitia, or older versions of the book have another name for it. Tunica externa, I believe. I think it's externa. It's the outermost layer, and it's fibrous. It has some kind of connective tissue, so CT properties on this adventitia. That's smooth muscle, and that's endothelium. Kind of showing you there. If you look at a cut artery and a cut vein, the artery is going to keep its shape because it has a thicker tunica adventitia here, and it has a thicker tunica media. So, so it's really due to thickness and elastic properties. Veins, much thinner. Remember, veins are low pressure system, and arteries are high pressure system. And so this goes through, you know, why the endothelium appears rippled in arteries, because arteries have to expand and then contract. And so the endothelium can't just be one sheet. It has to have the ability to expand and relax. Distinguishing arteries from veins. Again, this goes through, you know, you have this rippled endothelium. You have a band of muscle and then a band of elastic tissue around that muscle. And you're going to have this kind of elastic fibers running through it, so it can keep its shape and snap back and keep the pressure up there. So this kind of goes through all of those. The vessel lining in arteries is rippled for when it expands, and then it becomes rippled again when it contracts. And then a main thing with veins is most veins have these one-way valves to prevent backflow. Because veins are a low pressure system, it's hard to keep pushing blood back to heart. You need to keep pushing blood back up to heart. And so these valves kind of will close behind the blood, so it can't drop back down. It keeps going forward. So we'll go through those valves in a minute. But distinguishing arteries from veins, this is a little chart that helps you kind of go through it. And again, I believe this is the chart in your book. Okay, so with arteries, you have the biggest ones are called elastic arteries. The medium ones are called muscular arteries, and the smallest are called arterials. So elastic arteries are the big ones, right? So this is your aorta, your subclavian, and etc. So these are the big ones. They have a lot of elasticity to them since they're closest to the heart. They're having to tolerate the biggest pressure fluctuations because this muscle right here is pumping. And so it's a high pressure here and a high pressure here. And so it needs to be able to expand and contract with that increase of pressure. So that's the tolerate pressure during changes in the cardiac cycle, which is your heart filling up with blood and then your heart contracting. And it has to be able to expand and then immediately recoil or snap back in order to keep the blood moving forward through that closed system. And so there's some examples of the what we would call elastic arteries or conducting arteries. Muscular arteries, they're mainly known as distribution arteries because they're the medium-sized one that have the most smooth muscle. And so this smooth muscle is under the control of the autonomic nervous system, which is the sympathetic nervous system and parasympathetic nervous system, right? So fight or flight or rest and digest. They control the diameter of the tunica media in these muscular arteries. So they can constrict and make the diameter smaller, or they can relax and make the diameter bigger, right? And so you have the ability to kind of control blood flow. So vasoconstriction, again, is the contraction of the smooth muscle. You're going to decrease the diameter, and that's going to decrease blood flow downstream of where that constriction is going on. If you dilate, you increase the diameter, relaxing the smooth muscle, and that will increase blood flow. So we kind of end up going through this a lot more in physiology. So this kind of gives you examples of muscular distribution arteries here. Now, arterials, they're small arteries, and they control blood flow between the arteries and the capillary beds. So these arterials are kind of controlling how much blood goes into the capillary beds. And then the smallest exchange vessels are the capillaries, right? And most capillaries are continuous, but you have some with little bigger holes. These bigger holes are called fenestrated in the kidneys, endocrine, brain, or the sinusoids, which are liver, bone marrow, adrenal gland. But most of them are continuous. And we discuss in physio really how things are going to move in and out of these blood vessels, right? And how things diffuse across. This is showing you an arterial here, and it's controlling the blood flow through a capillary bed. So capillary bed here. And if the tissue is highly metabolic, right? So you're exercising. So say this is increased exercise equals increase in need for oxygen and nutrients, right? So you have to increase the blood flow. You're going to open up every single area of this capillary bed, right? And what allows that are what are called pre-capillary sphincters. So this pre-capillary sphincter muscle will open up or relax or dilate and allow blood to flow all the way through all the different capillaries of this capillary bed. If you don't have high metabolic needs, right, so you're just at rest, then the pre-capillary sphincter closes down, and blood will just kind of go through a meta-arterial or through channel, right? And then go to the venous system and start going back up to the heart. So you get a little exchange of oxygen, right? Or whatever you need, but you don't need too much. And so I have that backwards. So that's what a meta-arterial is, a through thoroughfare. or meta-arterial. So when you say arterioles, they control these, they have these pre-capillary sphincters. So they're controlling blood flow through. And so this goes through meta-arterioles. An anastomosis is having more than one route to a given area or tissue bed. And so in areas where you want to make sure you have constant blood flow, there, like the heart and the brain, there's going to be anastomosis or multiple areas of blood flow going to the same tissue area. Veins are kind of small, medium, and large, and they're bringing blood back to the heart. They have these one-way valves, and they're really in the muscular arteries. And so when you look at these one-way valves, in addition to the one-way valves, you use your skeletal muscles to squish the veins, right? So the muscles of the legs squeeze the veins to push blood up past a valve, and then the valve closes behind that blood, right? So the blood can't go down. So you're using the skeletal muscle pump and also your abdominal thoracic pump, these muscles contracting or compressing to squeeze the veins to push the blood back up to the heart, and these valves keep the blood from going back down, right? Resisting gravity. So here's showing you these one-way valves in the veins. So you're squeezing, right? So here's the skeletal muscles contracting, and it's pushing the blood up and up, and then these little valves close behind it. So the blood's going one way back up to the heart. That's one reason why if you sit for a long period of time, say in an airplane for 5-6 hours, and your feet are just going straight down and you're not actually contracting your leg muscles, right? This isn't happening when you're sitting for long periods of time. You start to have the pooling of blood down in your feet, right? Your shoes get tight, they feel tight. Your shoes are feeling tight because you have blood that's pooling in your feet because you're not contracting your soleus and your gastrocnemius and those muscles that have the superficial veins and the deeper veins. And so they're not contracting, they're not pushing the blood back up to the heart, and you have pooling or kind of fluid pooling. Large veins don't have valves. There's basically almost no pressure. By the time you get up to your abdominal area, you're using your abdominals actually to compress when you breathe the inferior vena cava. And the superior vena cava is kind of relying a lot on gravity. And you might notice your arms, when your arms are dangling down at your side and you're not using your muscles very often, you will have finger swelling. Again, you got to contract those muscles. So constriction shifts blood. Distribution of blood, most of your blood, so TBS is total blood flow, right? So that's flow, and this is volume. But most of your volume or flow is in the veins. 30 to 35% are in the arterial system. So 13% of that is in the systemic arterial system, and then 7% in the coronary. Only about 5% of the square footage of your blood vessels and blood flow is going to be in the pulmonary arteries and capillaries. The rest of this, by the way, is the veins. So most of your blood here, 65–70% is in the venous system. Remember, it's a low pressure system. You have dual drainage in your arms and legs, which means you just have more square footage of veins. So again, blood vessels, their pulmonary circuit or their systemic circuit. If you look at the overall, I like this diagram because it really kind of does simplify it. And then here's your heart. This is systemic circuit on this side, right? So this right here is the pulmonary circuit. And then this is the systemic circuit. going all the way back, right? So all the way. And you have, you know, branches, 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 branches. And then you have merging, 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 right? Until we get back to the heart. Pulmonary circuit is obviously for gas exchange. This is showing you, again, when you look at this right here, I hope you realize that this is a pulmonary artery. It's the pulmonary trunk. And these blue things, these are all pulmonary arteries. And then you look at the red ones. Oops, it's going to be a pulmonary vein. These lines are a little bit off. And this is. So these are pulmonary veins. They're red. And the pulmonary arteries are blue. Why? Because you are getting oxygen in the pulmonary system, right? So even it's blood leaving the heart, but it's deoxygenated blood. And then it comes back oxygenated, right? So it comes back after going to the pulmonary circuit and getting new oxygen and getting rid of its carbon dioxide. So blood on the left side of the heart enters the system, systemic circulation. You have the ascending aorta, the aortic arch, and then you have the major branches, right? The brachiocephalic branch, which branches into the right common carotid, right subclavian, and then the left common carotid and left subclavian. And then it becomes the descending aorta. The brachiocephalic itself, right? So here's brachiocephalic, and then it branches to the common carotid, and then it branches to the subclavian, and off that is the vertebral. So this is the vertebral artery going up. So you have the carotid and you have the vertebral artery both going up. So that's kind of what this is talking about here. Both sides. By the way, your carotid sinus, this is where you can feel your pulse. So you go right under your mandibular angle and you kind of go down under your mandibular angle till you feel like a little ball. And that little ball is going to pulse. And you will have hit your carotid sinus. You feel your pulse the strongest there. Why? Because it's closest to the heart, where the heart is pumping. So it's just going to be the strongest. It's going to have the most pressure. That is also where the internal carotid and the external carotid split after the, right there at the coronary carotid sinus. You also have baroreceptors and chemoreceptors in the carotid sinus. They're they're really checking pressure, right? So blood pressure, stretch on the artery, and they're checking for oxygen and carbon dioxide levels. Branches, you don't really need to worry about too much. You have the branch that goes to your eye, and then you have the anterior cerebral artery, and then you have the middle cerebral artery, and you're going to have a posterior cerebral artery. So you have these branches off the internal carotid, and it forms an anastomosis. And this anastomosis is referred to as the circle of Willis or the cerebral arterial circle. And so really it is this right here, which is kind of like, I don't know, I call it the Martian Willis, right? So that is Willis. It's really a multiple routes and then a roundabout to make sure that there's always continuous blood flow. So not only do you have all these major vessels, but they're actually connected with a roundabout. So if you have a blockage, say here, that's okay. Blood can still come from this side to get there, right? So there's multiple routes for the blood to go in this cerebral arterial circle. And so it looks to me like a stick figure. I always draw it like this. It's a stick figure with no neck, no neck. And so the legs are the vertebral arteries. And then the body is the basilar artery. And then you have the arms, which are the posterior cerebrals. And then these posterior cerebrals communicate. There's the mid-cerebral that goes across. Goes across here. And this would be the posterior communicating arteries connecting the basilar to the mid-cerebral or internal carotid. And then here you have the anterior communicating with the anterior cerebrals. So, so I do want you to know the main arteries of the cerebral arterial circle or circle of Willis. So this kind of goes through that. And again, this is showing you anterior cerebrals, internal carotid and mid-cerebral. They encircle the pituitary gland, and the posterior cerebral, basilar, and vertebral, right? And then you have the communicating here. And if you guys didn't get it, here's Willis. He's all blown up. And you can see right there. Right, so anterior cerebral, posterior cerebral. Okay, vessels you need to know going down the arm here. So again, you have the right common carotid, the right vertebral, and then it becomes the subclavian, right? So we got the subclavian. And here's the vertebral. I don't really go over the thyrocervical, but you can go over that if you choose. This is going to be the same on the got the right common carotid. This is brachiocephalic. And then this is the aortic arch, and then you have the left common carotid, left subclavian. All right. So off that, we don't really go over the internal thoracic, but the subclavian, as it passes in the armpit area, is known as the axillary. And then as it travels down your arm, we call it the brachial. And then it's going to split, and the brachial is going to split into the radial and the ulnar, right? And then you have these palmar arches and digits off that. It's going to be both the same on the right and left, so you can see. So we go axillary, brachial, radial, ulnar, superficial, and deep palmar arches and digits. Again, brachiocephalic trunk, left common carotid, left subclavian. Those are the three off the aortic arch. Then it branches to right common carotid and right subclavian. On both sides, you have vertebrals coming off the subclavian. And then you have right and left axillary, brachial, radial ulnar, and palmar arches. Then it becomes really the descending aorta. So the descending aorta, you go through the thoracic descending aorta, and there's a few I want you to know off the abdominal. So when it passes, so after diaphragm, it's then called the abdominal aorta. So if you're looking at this picture, right? So here's the diaphragm here, and then it becomes the abdominal aorta. And you have the celiac trunk and the superior and inferior mesenteric arteries. The phrenic artery, that is supplying the diaphragm from the inferior side. We don't really go over adrenal, but they're on top of the kidneys, the adrenal gland or suprarenal. You have the renal arteries, gonads, and then going all the way down to the right and left. I don't really go over lumbar arteries. Common iliac. So here, the first major branch on the descending aorta is the celiac trunk. And then the celiac trunk has, you know, every trunk has branches. It has 3 branches. So it has 1, which is your left gastric. And then it has 2, that is your splenic. And then the third here is the hepatic, and I covered it up. So hepatic artery, right? So 1, 2, and 3. It's going to go here. Then the next branch is the superior mesenteric artery, and that's here. That branches off here. And then the lowest branch is the inferior mesenteric artery. There. Eventually, it's going to terminate, the aorta is going to terminate, and it's going to branch into a right and left iliac. So you have a left common iliac, which is this one, going down, and you have a right common iliac, which is this one. The common iliacs are then going to branch into an internal iliac and an external iliac on both sides. So again, celiac trunk, you have the gastric, the common hepatic, and the splenic. So 1, 2, and 3. And then the splenic further splits into the left gastroepilotic and the pancreatic. You don't really need to worry about that, but you do need to know the celiac trunk. You have the common hepatic, which branches, the cystic goes to the gallbladder in the hepatic artery proper. You don't need to worry too much about those. So I want you to know the celiac trunk, and these are really the important ones. You have to know the superior mesenteric branch and the inferior mesenteric branch. And so this goes through superior mesenteric branch and inferior mesenteric branch. Also going to your kidneys, by the way, and this is showing you, these are the renal arteries. And the ones going to the suprarenal or adrenal glands are up. All right, then it terminates here. And you have a right and left common iliac, which then further splits into an internal and external iliac. External iliac then is going to become the femoral arteries. So again, when looking at these, I want you to appreciate what it looks like here, right? Because you have the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. In these diagrams here, you have the celiac trunk, the superior mesenteric artery, the inferior mesenteric artery here. Again, external iliac then becomes femoral. And that's going to be a deep femoral. And the regular femoral goes behind the knee to the popliteal. And then that becomes a posterior tibial. There'll be a branch comes around the front, the anterior tibial and the fibular. So just name for location. As far as veins are concerned, all of the deep veins pretty much share the same names as the deep arteries with a few exceptions. So those exceptions are going to be, instead of the aorta is an artery, and the inferior vena cava and superior vena cava are veins. So where you see the aorta here, this right here is the inferior vena cava, right? So those names are different. The hepatic portal system is different. You have the celiac trunk and the superior and inferior mesenteric arteries, which then become veins that become one big vein that goes to the liver, and that is the hepatic portal system. So we'll talk about this a little bit later. You also have the carotid artery going up, and we have the jugular vein coming down in the neck area. So that is different as well. So venous drainage is a little bit different than arterial blood flow. And so we'll talk about those differences. The neck limbs have deep and superficial veins, right? And we call that dual drainage. And arteries are only deep, right? So again, veins that are a little bit different, superior and inferior vena cava. The superior vena cava is getting blood or receiving blood returning to the heart from the head, neck, chest, shoulders, and upper limb. So everything above the diaphragm. And so this kind of shows you drainage back to the superior vena cava. Now let's point out a few things. You have the cerebral arterial circle. You have the the anterior cerebral, mid-cerebral, internal carotid, posterior cerebral, and all the communicating, the basilar, the two vertebrals, a lot of blood flow. All of those veins just dump venous blood into the sinuses, the dural sinuses. So the dural sinuses receive all this blood, and it's like a reservoir sewer of blood, and they then drain either to the vertebral veins or the jugulars. And those will then bring blood back. This is the subclavian vein, and it's going to merge with the jugular veins and vertebral veins. And these are going to merge, and this is going to be called the brachiocephalic vein. And you have two brachiocephalic veins, right? So you have a right brachiocephalic vein and a left brachiocephalic vein. You only have one brachiocephalic artery. You have a right brachiocephalic artery, and then a left common carotid and a left subclavian, but you have two brachiocephalic veins because the jugular veins and the vertebral veins merge with the subclavian to become the brachiocephalics on both the right and the left. So that is coming from the dural sinus drainage from the brain to the jugular veins and vertebral veins. They merge with the subclavian veins to become the brachiocephalic veins. So this kind of then talks about the brachiocephalics, right? So that's going to be the left brachiocephalic, and that is the right brachiocephalic. And then this would be the superior vena cava. As it goes subclavian, right? So you have two subclavians here and here. And then really, I guess it's going, blood flow is going this way, by the way. So you have some superficial veins. So this is superior vena cava, right? And that's the brachiocephalic. And these veins are named a little different. So you have the cephalic vein, which is this one. And then the next superficial vein you have is the basilic. And then you have a superficial vein that combines the two, and this is the median cubital vein. And then this one right here is the median antebrachial vein. So those are the superficial veins in the arms. Kind of an easy way to remember, you don't have to remember this, but you have this tributary vein called the azygos, and it starts with the letter A. And then the next vein is the basilic, and then the next vein out is the cephalic, right? So it's ABC. So if you just remember, B is going to be the medial one, basilic. C is going to be lateral, that's cephalic. So these kind of go through these veins. Remember, blood flow is going kind of up this way. And so it basically starts with palmar, right, into the median cubital, which connects the cephalic and the basilic veins, which then merge and become axillary veins along with the brachial vein, and then subclavian vein, brachiocephalic vein, and superior vena cava, because it's going that way. So veins that are named different, right? So azygos, I think I show you here. The azygos is this tributary. And remember, A is in the middle, so A, and then B, and then C, ABC, on both sides. So basilic, cephalic. Remember, jugulars are named different than carotid. Median cubital and median antebrachial. Inferior vena cava and superior vena cava, and these are brachiocephalics. And you have the jugulars. On the hepatic portal system, so again, you have the celiac trunk and then the superior mesenteric and inferior mesenteric. Well, all of the venous blood coming back, you do have an inferior mesenteric and you do have a superior mesenteric, which is here, right? And they're going to merge with the splenic here. And the gastric's going to merge, right? So they're all merging, and they merge into this one vein that goes through the liver, and that's called the hepatic portal vein. And then all of this nutrient rich, because the superior mesenterics are absorbing nutrients from your small intestines, right? And so this is nutrient rich blood here. And that nutrient-rich blood is going through the liver before it goes into the inferior vena cava. So most of the time, like if you look at the renal blood flow, you have a renal artery going into the kidney and a renal vein coming back out of the kidney. This is a little bit different. You have all of the veins merging to become the hepatic portal vein. So all veins merge into the hepatic portal vein in the abdominal area. Then it sends all this nutrient-rich blood from your intestines through the liver, because the liver has over 200 functions, and a lot of them are metabolic functions. Stores glycogen for cells of your body, does all kinds of stuff. And so the liver really gets first crack at your nutrient-rich blood that you just absorbed from the small intestines, and then it sends it into the general circulation of the inferior vena cava. So read through these. It talks about, these slides kind of talk about the hepatic portal system, inferior mesenteric, splenic, superior mesenteric, and this kind of shows you the blood flow, right? All the way up. Two superficial veins in the legs that are named differently. And remember, we're going back up. So the deep veins are named the same, but you have this long superficial vein called the great saphenous. And then on this side, you have the small saphenous. I think this shows you, right? So this is posterior. And I'm saying that because the small saphenous is always lateral, and the great saphenous is a medial vein. So it goes the entire medial length of your, so here is your great saphenous, all the way up into the femoral. Small saphenous is just on the side. So those are the main veins. Last, I want to finish up with my little in and out talk. So aging is not kind in general. Hematocrit levels naturally drop, which means you have less red blood cells, which you have less oxygen carrying capacity, which your cardiac, I should say your your VO2 max, or your volume of oxygen that you can consume, goes down. That just means your cardiovascular fitness goes down, right? As hematocrit levels drop. This is just a part of aging. Your valves start to break down in your veins, right? So you have a lot more pooling. You can get blood clots, a thrombosis or pulmonary embolism if that clot then gets into your pulmonary circuit. Not good things. But I want to say, you know, your cardiac output max drops as you get older naturally. Your heart muscle gets a little bit older naturally. But the things that are not as natural, that their lifestyle, is atherosclerosis and arterial sclerosis. So this is really atherosclerosis here, right? And so what it is you have all this plaque that is sticking, right, to the walls of the artery. And that plaque is decreasing the diameter. And what that does is it decreases blood flow and increases pressure. So atherosclerosis is really this fat plaque sticking to the endothelial lining. And it decreases the space here for blood, right? And so that's going to actually lead to increased pressure. And arterial sclerosis is, you remember how stretchy it's supposed to be, elastic? These walls are supposed to be able to stretch and then come back. Well, if you have all this plaque built up, the walls are no longer elastic. And that is arterial sclerosis, is that your vessels can't really expand and contract. And so they can end up tearing, which is an aneurysm, where the wall breaks from this loss of elasticity. So that is arterial sclerosis. So atherosclerosis is where you have lipids deposit and these plaque diameter, and that plaque results in a decrease in diameter, an increase in blood pressure, decrease in blood flow, all of which are bad, right? And then it stiffens the walls, and then you can have arterial sclerosis, right? So these are not good. They call it the in and out artery, which is crazy because the line in and out never seems to be less than 3 laps around 24 hours a day. So we're doing it to ourselves. That is a lifestyle thing. You can't help getting old, but you can help getting diseases like arterial and atherosclerosis and fatty liver disease and all the horrible things that happen. So that's it. And then we'll move on to the lymphatic system.